This is Ike Ahmed,
And I'm Arsham Shaybani.
and we want to welcome you to GT the Podcast
We're bringing this to you together with BMC and Glaucoma Today,
to offer audible insights into current topics in glaucoma care.
presented by the authors of our latest, most read GT articles.
Check it out.
Welcome to another episode of Survey Says with Dr. Paul Singh. On this special edition of GT the Podcast, Dr. Singh presents a real patient case from his practice and asks his guests to share how they would approach it. Today's episode features Drs. Lori Provencher and Brian Schaefer. The case involves a 66-year-old monocular patient with high myopia, a significant dense cataract, and a recent diagnosis of moderate primary open-angle glaucoma. The patient is on 3 classes of medication, but has difficulty with compliance. He wants to reduce eye drops and dependence on glasses as much as possible. Dr. Singh asks the guests to share what type of surgery they would choose and which factors would most affect their choice. They weigh their options considering the patient's goals, monocular status, and relatively young age. They discuss how to manage the case in the most effective manner while still leaving options on the table for future treatment. They also consider whether treatment should be aimed at reducing IOP or reducing the medication burden. Later, the guests find out what Dr. Singh did, as well as how GT's audience reacted to the case, based on results of a social media poll. Tune in to Survey Says with Dr. Paul Singh.
All right, everybody, welcome to another episode of Survey Says. My name is Paul Singh out in southeastern Wisconsin, and I am so excited and so pumped to be hanging out with 2 really good friends, awesome educators and surgeons, and just awesome people, Lori Provencher and Brian Schaefer. Hey, guys.
What's up, Paul? What's up, Lori?
Good to see you guys and good to talk to you guys. Actually, want to introduce, so Lori, tell everybody where you're from. I know you moved recently, so tell everybody where you're at now.
Yes, I have been in Omaha, Nebraska now for 1 year. I'm at Vance Thompson Vision at the Omaha office, and I do glaucoma and I don't do cornea. I feel like some days because I'm around so many cornea surgeons, I do cataract surgery as well.
Awesome. And of course, talk about Schaefer Vision Institute.
Yeah, I'm Brian Schaefer. I started the Schaefer Vision Institute in August of 2023, so we're just over the 1-year mark there. I'm in the greater Philadelphia area, and I do kind of full-scale anterior segment, cataract, refractive, cornea, and glaucoma. My practice is very heavily surgical and very heavily interventional glaucoma based.
I love it. I love it. To my peeps, we always talk about all the cool technology that we get to use and kind of the new paradigm shift that's occurred in glaucoma, especially with MIGS and, of course, SLT and now DSLT and drug delivery and all the cool stuff we do. And the idea of Survey Says, everybody, is just so we all are on the same page. I have a case, and it's a real case that we submitted online to a bunch of the different social media outlets like Instagram and LinkedIn and Twitter. And we just want to kind of get a polling of what would doctors, surgeons to do out there, what kind of surgery would they do based upon the case, what are some of the risk factors, and why did you decide to do what you did? And so what we do is we have two of our fine surgeons here who are going to kind of talk about kind of the case with me, and then we're going to kind of talk about the results of the polling and see if that kind of aligns with what we would do and just kind of have some fun. So it's kind of real life, a lot of fun, and just there's no right or wrong answer. And so with that, I'm going to kind of just start off, guys, with just making sure everyone knows what the case is all about. And I'm going to ask you guys some questions about the case before we get into the results and get into what you guys would do. Okay? Sounds good?
Let's do it.
Awesome. Okay. So there you go, everybody. So we have a 66-year-old high myope, -10, now about a diopter and a half of cylinder as well, monocular patient. So lost a vision from one eye from trauma many years ago. It's an African-American male. Moderate glaucoma, MD about -6, and had a pretty dense, really fun, dense, hard, like nuclear sclerotic cataract, 2200. Open angles, cerebral body, pressures around the 19 range on 3 classes of meds. Dry eye, difficulty taking drops, affording drops, the typical compliance stuff that we deal with every day. A little bit lower hysteresis around 9. Cup discretion about 0.65, but really had a diagnosis of glaucoma recently. And so I didn't have any history of like field loss and progressions. All I had is one field test that's available, which showed, again, moderate loss, but nothing near the central fixation. So with that said, his patient's on 3 meds, wants to get off of drops, wants to be also off of glasses as much as possible, wants the best quality of vision for distance, has high myopia and significant astigmatism. So I'm going to talk to Lori. What do you think? So you get this case, it's monocular. What are some of the things you're thinking about right now? What are some of like the kind of the worries that you have right now with this patient?
Yeah, I think a lot of things, and that's probably why you picked this case. But obviously, this is a high risk patient that should cause you to pause in clinic and really think about your next move. Make sure you get it right. So, even at 19, with his risk factors of being 66, already having moderate disease, being a monocular African American, um, I think we can probably say that 19 is too high for him. And then he has about every medication related problem that we see, non-compliance, ocular surface disease, difficulty taking them. So I think you're going to, just first thoughts is I'm going to want to do something that is highly effective at not just lowering his pressure, but also lowering his medication burden. Also something that pairs well with cataract surgery, and then also something that still leaves options on the table for the future because he is just 66 years old.
Yeah, no, good point. So what about you, Brian? What do you think?
I agree with all of that. The things that I'm wondering about here in this case is the things that we don't quite know just from the vignette. We do know the corneal hysteresis is 9. Not ideal, not the worst, but not ideal. We always have to wonder, what is this person's untreated IOP? Like, what were they when they first came in? Are they 19 but they were at 35 when they first got diagnosed? Or are they 19 and they only came down from 22 on 3 classes of meds? Of course, that's relevant, important information that I'm sure we would normally in a clinic setting have available to us. We also, of course, want to know central corneal thickness. We do have the hysteresis, which may be a more dynamic measure that relates to that central corneal thickness. But those are just the things that I would want to know before making my final determination on what I'm truly going to do. This case is where I would split it into 2 separate things. One is the glaucoma piece, one is the refractive piece. This is what all 3 of us on this call actually love to do. And I really love this case because there's a lot of interesting things to talk about here. Specifically, what sort of contrast loss does somebody who's monocular with a mean deviation of -6 have? What lenses will work well monocularly versus if you had 2 eyes to work with you? But again, we'll separate that into 2 things. On the glaucoma piece of things, I agree completely with what Lori said. We need to make sure that we can get this patient's pressure under better control, but also save room for the future because this is not a very old person. Additionally, at moderate glaucoma stage at this point in time, we're going to assume at 66 years old, let's just for simplicity's sake, let's say this person has Medicare and a supplement just to make our lives easy. We're going to assume that as a moderate POAG patient, they're eligible for really almost everything we can do at the time of cataract surgery, at least in my MAC. I know that recently has changed in your MACs where you're not necessarily able to combine glaucoma procedures as well. In my MAC in Novitas in the Philadelphia area, that's not happened yet, thankfully. So what I'm thinking about in somebody like this is how many glaucoma things can I do to this eye while also saving room for the future? And within some of these results of the survey, I agree with all of the answers really, because there's no wrong ones. But my personal approach in someone like this is I think about every medication equals a different MIGS procedure for that person. So they're on 3 meds, they're going to get 3 different things in my hands here. They're going to get some form of canaloplasty, some form of stenting, and ideally some drug delivery in the form of iDose at this point in time. From the refractive side, let's jump into that later, but I'm curious, what are your thoughts on what I just said about the glaucoma piece?
Lori, go ahead. Why don't you answer that? I'll give my thoughts too.
You see my eyebrows hitting the ceiling? Oh, um, I think, I am not nearly as proficient as Dr. Schaefer when it comes to the billing and coding side of things, but in general, I try to keep it as simple as possible. I do think Hydrus is the first thing that came to mind with the data we have from the Horizon trial, the powerful medication lowering, the longevity of the effect. And then of course, if you can and make sure it is covered, you could do a viscodilation as well. So that's going to potentially give you a little more power than the stent alone. I don't think we have data really to show us that yet. But um, adding in the drug delivery piece for me so far has, and I agree, he may need drug delivery, right? The odds of getting him off all medications, I can picture that table in my mind that we have from Alcon when it comes to lowering medications. But I think getting him off all three medications with just a hydrous and or viscodilation um, might not be possible. So yeah, drug delivery might be in his future, but I think it's also something we could save for the clinic with something like a Durista if we needed to augment later. I think so far for me, I've just been too uncertain with reimbursement when it comes to pairing drug delivery with a mixed procedure.
No, these are really good points, and I'm gonna tell you kind of my thoughts in a second. What I did, of course, too. But before I go there, let me back up a little bit there because you guys, we talked about information. So yes, this is Pachymetry. We're sorry I didn't tell, and that you guys know that is around 550 range, so pretty average. I don't know the T max, and we did not do a washout for him as well. So that is something that you're absolutely right. It's good to know. Did you start with 35 or did you start with 26? How effective are the drops? So we don't have that information. But my question to you guys is, in a case like this, where you have a monocular patient, we do have moderate glaucoma, no central loss. To me, somehow, in my experience, getting someone off of medications and stabilizing them that way is now, in my opinion, and kind of my experience, been as important for some of these patients as the absolute reduction of IOP. So even if a patient's pressure is, let's say, 18 after surgery, but he's off of medications and stable, I'm not worried about compliance. In some ways, I am as confident and comfortable for a lot of these patients, at least for a while, not forever, but for a while, versus, let's say, someone's back on a med or two and pressures are ranging, between 14 and 18 or 14 and 16 or 13 and whatever it is. So my question to you guys is, how valuable, how much of a goal is getting off of meds for you guys for this patient? Or how much of your goal is to get the pressures down, or is it equal? Anyone want to comment on that?
I'll jump in on that. I 100% agree. I think if we can control him with fewer medications and maybe even have him in the same kind of bin of IOP range and agree that we're going to watch closely, I think that's more valuable. I mean, there's triggerfish data that shows that Hydrus can stabilize diurnal fluctuation more than medications can. I think that's all something we would agree on. And then you've got other studies that show better disease control with interventional procedures than drops alone. And a lot of that we think is coming from that flattening of fluctuation. So strongly agree. I also will add in that I often feel more comfortable offering maybe a presbyopia correcting lens that might cause a little contrast reduction if I'm pairing that surgery with a MIGS procedure, because it's giving me more control over the patient's disease and hopefully less glaucoma over time, so that I worry less that multifocal or whatever diffractive optic you might talk about them with is going to maybe cause trouble down the road. So I do that a lot.
Yeah, I want to talk about that too, because I think we talk about contrast sensitivity loss with presbyopia lenses or EDOF lenses. But if you have someone who is on 2 or 3 meds and their surface is looks like crap, their tear from breakup time is like 3 seconds, and they have SPK, their contrast is far worse than any IOL that you're going to put in. So the key is get that tear film as stable as possible. You'll be helping these glaucoma patients a lot as well. So that's why the drop reduction is so important. Brian, what are your thoughts what Lori was saying and what we're talking about with in terms of, how much of your goal going into something like this kind of procedure is getting them off the meds, or is it really, I want to get the pressures down, I don't care?
It really depends on where their starting pressure is here. So this person has a physiologic IOP on medication. Therefore, my goal is to reduce their medication burden and maintain a physiologic IOP. Conversely, if they come to you on 3 meds, their pressure is 25, there's a different goal at hand here. The goal there would be ensure that you can get them to a physiologic IOP, even if that still requires potentially utilizing some medication. That being said, if the goal is really get them off of medication and get them to a physiologic IOP when they're on 3 meds and supraphysiologic, that's where we're talking about different surgeries here. This is where we're talking bleb-based surgery versus angle-based surgery.
I'm glad you brought that up because that's I want to go there. It's like, yes, angle-based surgery, we may not be able to get them down to 12, 13 range, but is that our goal? May not necessarily be. But if I try to get them off of meds, that's where the question is, will a hydrus be enough to get them off? It could be, but will maybe a combined, canaloplasty and I'll say a stent like a hydrus be enough? Maybe, or adding another drug delivery to that. Can that even hedge our bets even more? And that's kind of where I'm trying to go with all this. So bottom line is, I think that's the question we have to always ask ourselves. And, in the audience too, and when we're thinking in our chairs, that's kind of what's going through my mind as well. It's like, okay, what are my goals? And to your point, Brian, if someone's pressure is high, then my goal is just get the pressures down. If I can reduce the drop burden as much as I can, great. But then we have to talk about, okay, this guy's monocular. So yes, I think a blood-based surgery like a Zen would be a great opportunity to get them off of meds, get them pressures down, and you're pretty much going to hedge your bets that way, and you're going to get them down in the middle teens probably without drops. But having one eye, I want the safest outcome, even though a blood-based surgery like a Zen is very safe. This is where I'm going to try to maximize the conventional pathway as much as possible. So I'm going to tell you what I did. Then we'll go to what the IOL choice I used too. But what I did was to copy Brian. This patient did have Medicare, and he had a fee for service with supplements. So I didn't tell you that ahead of time. So luckily, and this is before the LCDs came out. This is about a month or two ago. So long story short, I did do an eye tract canaloplasty with a hydrus and an iDose. So I kind of went. I copied what Brian said. But the thing is, could a hydrus have done enough to get him off of the 2 or 3 meds? But absolutely, it doesn't mean you have to do all these things. I just wanted to hedge my bets because this guy is monocular, African American, he's young. And I'm like, look, I want to do everything I can safely to maximize the outflow of this patient. So that's kind of what I did and why I combined all those. But by no means do I feel like you have to have all those 3 to get to the outcome we had. And right now, this patient's really at around 14 off of medication. So he's doing great. And so I think that's what helped me a lot to feel comfortable going into surgery, telling this patient I have a good chance of getting you off of drops because we did the drug delivery with the canal dilation and the stent as well. But great points. And I guess my question now, though, is let's say you decide in your mind you're going to do X, Y, and Z MIGS, hydrus or the combo like you did, Brian. But what kind of IOL are you going to choose for this patient? Again, monocular, moderate glaucoma. We do know he probably has some loss of contrast. What are you thinking? You don't know if he's going to be off of all the meds depending on what you do. So how do you decide on what lens to put in? Remember, he's about diopter and a half of cylinder as well.
Yeah, so I'm gonna always assume whenever we're talking about correcting somebody's vision that we're gonna correct their astigmatism. Let's just use that as like in the background. Of course, we would do that. We would never not put somebody's astigmatism correction in their glasses. And if we have the ability to do it at the time of cataract surgery, why wouldn't we do it? And $1.50, whether it's with the rule or against the rule, we're in range to be able to use a toric lens. We're in range to use an LAL even. In this situation, this is a high myope, like a super high myope. We're talking like pathologic myope, a -10. That means his focal length at baseline is 10 centimeters, which it's very important for us to fully assess with this person. Does he use his superpower all day long of taking his glasses off to look at the lines on his hand or look really close? There is no more frequent unhappy post-op patient in my clinic, whether my own or referred from someone else, who was a prior medium to high myope, who someone took away their superpower and set them for emetropia, and now they're planosphere in the distance. They can see the stoma on the bottom of the leaf on the tree 2 miles away, and they hate it because they lost their superpower and they can't see the food on their plate and they can't see their makeup when they're putting their makeup on the mirror. That is the number one most important thing to assess in this patient, in my opinion. Any myope, make sure that they're not going to be very upset when they lose their superpower. Now, in this person in their 60s, still a -10 means they made it through the heyday of LASIK without having LASIK. They've chosen to keep their myopia all of that time. And now they're saying, I'd love to not have glasses for the distance. Because on the surface, it sounds like a really awesome idea. But in reality, that's the most important thing to assess is, are they using their superpower? If yes, don't take it away. If no, meaning they're wearing contact lenses for distance and wearing readers already, then to me, this is fairly cut and dry, toric monofocal distance. I don't think that it's of this patient's benefit to monocularly have any sort of optics that are going to extend the depth of focus here, because those lenses almost all work better with binocular summation, and that is not an option when you've got a prosthetic. So that's my long-winded answer.
No, good stuff, man. What about you, Lori?
Couple thoughts. Well, I agree with you, Brian. Those are most often the patients who are disappointed, bordering on upset, sometimes frankly upset, as if you take away their quote unquote superpower, as you call it. So the question to always ask is, do you take your glasses off to read or to look at small things up close? So I make sure to ask that of every patient, and make sure they understand, take extra time with them to make sure they understand what distance vision is if they opt for distance vision. Um, I don't necessarily agree with this point, but I will bring it up that traditional teaching is that monocular patients should always wear glasses. And again, I'm not saying I agree with that. I agree with your plan, but just this week I was in a surgeon thread where people were talking about, blanket statement, doesn't matter what their refractive error is if they're monocular, not to put a toric or advanced lens in that eye. And so I think you'll have some people arguing that that patient needs to constantly wear protection because they're monocular. I just would love to hear your counterpoint.
So I think that even if you do decide to wear glasses, if you're one of those people who says, you know what, if they're a monocular, I want them to wear protective glasses, there's enough data out there with astigmatism correction in the IOL versus the spectacle plane. And the quality of vision, the contrast sensitivity is so much better, even at a diopter, diopter and a half. If you take care of astigmatism in the IOL itself, near the focal point or near the nodal point, you will actually find better quality of vision for contrast. So I think for glaucoma patients, I tell them all the time, look, I know you can wear glasses. I know you can take care of astigmatism in your glasses, but the quality of vision, night vision, contrast sensitivity is better if I take care of it in the eye versus in the glasses. So even if they have to wear protective plano lenses, I still feel like their vision is going to be better if we take care of the astigmatism. So that's kind of my counter argument to not doing it. I still think anybody who has astigmatism, especially in the context of glaucoma, I think you deserve to give them the best potential quality of vision. And that's kind of why I'm pretty bullish about offering astigmatism correction, especially in the IOL.
Yeah, and for the record, I completely agree with you, and I think
No,
that's a
I
great
believe you.
way.
I was just
I just don't want that to be a indication that I disagree, but I think that is something that people would bring up when you discuss that.
No, that's a really good point as well. So would you, so in your hands, you think astigmatism correction is important. So would you, yes or no, consider an EDOF toric option? Or would a monofocal toric lens be an option?
I would not. I think just a monofocal toric is what I would go for. I would love to see like a ganglion cell layer, that sort of thing. You said he doesn't have any central field loss, but I think Brian's point of if the fear is that he will miss his near vision, and EDOF is not going to get him anywhere that near vision that would make him happy anyways. The only thing would be a true multifocal that would give him even close to the near vision he's probably used to, and it's not even close. So I think I would not take that risk, and this patient doesn't sound overly motivated to take that risk either.
Yeah, so great points, guys. You guys nailed it. So first of all, he's 2200 in one eye, so he's just like, give me a good distance vision, doc. I mean, he's a -10. He never really uses vision for near. I mean, he wasn't those guys who held it like a 2 inches away from his eyes. So he was just happy. Give me good quality distance vision, and so that's why a monofocal toric is what I did decide to do for him. Although I've been very bullish about doing a light adjustable lens. If someone is more kind of more, I think, astute to perfect vision in certain distances, I think an LAL is a great option for these glaucoma patients. Great quality, great contrast with these light adjustable lenses. But for this patient, I felt good with my measurements. And so we went ahead and put a toric IOL, standard monofocal toric, and patient did great. I mean, of course, a little bit of edema afterwards because he had some significant dense cataract, but he's very happy with his quality of vision for distance. But I think to your points, if someone is -10, usually they're not really using their vision that much to read close as much. And, unless they really like the whole thing's like an inch across from their face, majority of the time they want really good distance vision. And for this guy having only one eye, he was so happy. Just give me good quality distance vision. So we ended up doing basically a canaloplasty, hydrus, iDose, and a toric IOL. That's what we ended up doing. But I got to ask you guys a question. In these high myopes, do you have any concerns about doing the MIGS procedures before or after the IOL, before the cataract's removed? Any thoughts on that? And these high myopes. Let's say his axial length is like 28 or something like that.
So I almost universally, this is not 100% of the time, but almost universally do my MIGS procedures before the cataract. And I do this on a high myope or not. The only exception here is a real high hyperope with a narrow angle that I need to deepen it before I get in there. But I like to do MIGS before the procedure because you've got the posterior pressure, the appropriate posterior pressure from the lens itself in there. And I just feel that the chamber holds its form very nicely before the surgery. If you have a dispersive viscoelastic in there, the combo you did is the combo that I typically do as well, the iTrack Advance and the Hydrus. And you can do all of that through a tiny little Hydrus incision before you even make a main incision. So that the eye is super stable. You don't have this super duper deep chamber like you'll get in a high myope after the lens is removed. But I do that again in both high myope and just a regular eye as well.
Lori, what are your thoughts? Do you differentiate patients and decide to do pre or post cataract, the MIGS portion?
No, I think you could copy and paste Brian's answer for me on that one. I'd love to disagree, but
I think we're seeing a lot more people moving to before the cataract. The reason I brought this up is because there's still a lot of, kind of a lot of different opinions on what's the best way to do it. Whatever is best for you and is really the best way to do it. But I will say for high myopes, I like to do it beforehand because you're absolutely right. Once you take that lens out, you have a large, let's say a long eye, the anatomy gets all messed up. You put some or even a cohesive viscoelastic, you deepen that bag, you deepen the chamber. All of a sudden, you're like vertical, trying to put that stent in there or do the canalplasty. And the anatomical structures just aren't quite the same. So I definitely do that if I can beforehand as well. In of course, narrow angle patients, high, really, really thick LTs, lens thickness really, really thick, I'll do it for the cataract surgery first. But just wanted to bring that up as well. But great conversation. I'm going to move on just to kind of hear what our audience members thought what they would do. And I want to get your thoughts on kind of what they thought was important. So we surveyed Instagram, we surveyed LinkedIn, and of course, Twitter or X. And we asked a couple of questions. First question was, what type of surgery would you do? And the most common answer was basically MIGS or drug delivery. The number two was combination MIGS and drug delivery. So those are the most common. About 60 to 70% said that. The rest of the 25% said basically subcon surgery, like a Zen MIGS or Zen MIBS Trab 2 kind of thing. But looks like everyone agreed with this idea of let's try to maximize the conventional pathway first, with or without drug delivery, whether at the time of surgery or after, let's say, doing a Durysta in the office later on if you needed to as well. So I think everyone agreed there. Number two on Instagram, what factor affected your choice of surgery the most? And really it was severity of disease was the common. And then it was monocular status. And third was number of meds. So I think severity, decided patients, that the audience really felt that would decide kind of what next to do. But the monocular status was a big second. What are your thoughts on that? Is that pretty much what you guys think too? That the monocular status kind of affected your decision, or do you think it was just purely on number of meds and severity?
It was definitely all at play there. The monocular status, I think, encouraged all of us to try and maximize safety as much as possible. The the stage of glaucoma being moderate made us all feel a little bit more comfortable staying in the angle at this point in time. The number of medications is relevant, but the one piece of that that's missing in the answer choices is the IOP at presentation here. So I think it's the number of meds with that IOP at presentation being physiologic, and I think that's what encouraged all of us to go in the angle.
Yeah, and I'll get to the IOL selection too, but LinkedIn and I think X pretty much the same breakdown. We saw most doctors and surgeons felt severity was a big part of it. Then it was number of meds, and then monocular status. Go ahead, Larry.
yeah, I think the other thing I want to point out is a quarter of people still chose a subconjunctival procedure on a couple different platforms. So I think it's important to talk about maybe why we wouldn't go that first route. You did mention that those can be powerful at medication lowering, but just for me, reasons not to do a filtering surgery here is there's multiple reasons, but young-ish African Americans often don't do as well with blood forming surgeries. He's a high myope, so high risk of hypotony. And then also this is combined with a cataract surgery. So to me, there's three big reasons that I'd be less optimistic about success. Now, down the road, if we need it as a standalone surgery when this patient's a little bit older, it might go a lot better.
Yeah, that's a really good point. I mean, and there's no right or wrong answer, of course, but to your point, I think when we're deciding, especially in a monocular patient, this patient is not advanced yet, thankfully. It has a nasal defect, but it's not at all encroaching fixation. And you have time. You're going to get the pressure down probably slightly. If you're back on meds, worst case scenario, then you can talk about doing something more later on. But you give this opportunity for this patient to maximize their outflow system in the safest way possible. So I think that's a really good point to brought up. But yeah, I mean, subconscious is still an option. I love Zen. I think it's a great opportunity. But probably higher needling rate with this patient, and especially at the time of cataract surgery, depending on your technique. Might need a little bit more 5-FU or mitomycin rather. So definitely got to be aware of those kind of risk barriers to success. But great point. Awesome. Any other thoughts, Brian, on that? Would you anyone want to add to the whole subcons discussion?
No other thoughts.
All right, cool. Well, last thing I want to talk about, let's talk about the IOL selection. So I'm looking at all the different social media outlets here, and it looks like majority of docs split in multiple platforms between standard monofocal and a monofocal toric. So there's still a lot of docs who believe, and no right or wrong again, that this patient would be fine with a monofocal, and it probably would be. A doctor and a half, is it worth it or not? What do you guys thought? What are your thoughts on that breakdown? And how would you convince a doctor who says, you know what, this patient is all they need is a monofocal standard, not a toric? How do you want to address that kind of conversation?
Yeah, I think that what Lori said before about that conversation likely is stemming from the old dogma of monocular patients need to have eye protection at all times. If they're going to have eye protection at all times, why bother putting in an astigmatism correcting IOL when you could just put it in their glasses? And I like what you said before, Paul, about correcting astigmatism closer to the nodal point of the eye does show enhanced outcomes. The other point of that is that the conversation would be, why have the patient, and I say this in quotes, waste their money on an astigmatism correcting lens if they're going to still potentially need glasses all the time to protect themselves? Well, the reality is that if you're getting true polycarbonate protecting lenses, if you have a planosphere polycarbonate lens versus a polycarbonate lens that has some astigmatism built into it, there's a very different cost there. And over a lifetime, that cost is going to be likely significantly higher when you get multiple different pairs of astigmatism correcting polycarbonate glasses compared to a toric IOL, which for the cost of it is going to be negligible over a lifetime of a 66-year-old. But at the same time, it's not completely unreasonable to say if you set this person for near, $1.50 of SIL is probably not going to impact them that much at near compared to at the distance. So for patients who are, if we let's say we target -2.5 as their endpoint, -2.5 with $1.50 of SIL, they're at one meridian. If they're in focus at near, they're going to be able to see, and they will be in glasses at distance anyway. So that's where I think some of the nuance of that conversation comes up.
Yeah, no, really good points. And again, there's no right or wrong answer for these, but I think I'm pretty bullish about the fact that you look at the vertex distance between the eye and the lens and the glasses, and there's sometimes that can be like even an inch or two sometimes depending on how people hold their glasses, and that's enough for light to scatter, especially at nighttime driving, things like that. You see a significant difference in data. So for me, I'm a big fan of just kind of offering that to patients as well, and not being afraid. Yes, it is more money, but I think that you are giving them value, and we can't be afraid to say, hey, this is the value we're offering for our patients. And I think we're getting past that kind of cost barrier now a lot more now because we have so many options for these patients. But man, this was great, guys. This is, there's so much more to talk about because of course, glaucoma is never easy and simple, but you guys did a great job of breaking it down. And I want to thank everybody out there in the surveys world of filling out that survey and giving us your honest opinion as well, because there really isn't any right or wrong answer, but hopefully there's some pearls that you guys heard out there that would help you in your decision-making process when you're in your exam room lanes. But Lori, Brian, you guys are awesome. Thank you for sharing your insights and your pearls. Any last comments you want to make about this topic or this case before we say bye?
No, I'll just say there isn't a right answer, but there is the thing that Paul did.
Yay! I love it.
My last comment is that Paul, we're so happy that you are with us, and so happy that you are on this healing journey and able to maintain such a good attitude despite all that you go through and all you do for us.
Oh man, you guys stop it. No, you guys energize me. This is the stuff that keeps me going. No joke at all. But thank you again, everybody. Take care, stay safe and happy, and take care. See you soon.
Thank you for tuning into this episode of GT the Podcast. If you have any feedback or topic suggestions, find us on Instagram, LinkedIn, Facebook, or Twitter. And stay tuned for more hot topics in glaucoma care on GT the Podcast.